afternoon, and thanks for joining us. I'm Judy Simpson. Our focus today is on your health and cancer. In partnership with the University of Vermont Cancer Center, we're able to share with you the very latest information from some of the top cancer experts in the country. Today we'll be learning about colorectal cancer with Dr. Mark Greenblatt. Dr. Greenblatt is a medical oncologist at the University of Vermont Medical Center and a research program leader with the Cancer Center. He's been with us before, and it is a pleasure to have him back on the program. Thanks so much for coming in.
Thanks for having me again.
Now, there's a lot to discuss, including screening, risk factor, prevention. But before we get to those different issues, you brought along a slide that helps us understand exactly what parts of the body that we're talking about.
Right. So when we talk about the colon and rectum, we're talking about the lowest part of the bowel. It's the end. It starts, as you can see in the figure, on your lower right side. That's where the small intestine empties into the large intestine, and that's the beginning of the colon. Rises up across the right side of the abdomen, across the front, down the left side, and then out to the rectum, which is the part of the bowel that stores stool until it can be excreted.
And that's like 6 feet in length.
About 3 feet, 3.5 feet.
Okay. So what exactly does the term colorectal cancer mean, and how common is this disease?
Well, for how common it is, it's the second leading cause of cancer death in the country. It affects men and women equally. Cancer in general happens when cells grow out of control. So all of the cells in our body are supposed to grow fast when they're young and then mature and do their job and then die in an orderly way and make way for the next cells. And so cancer happens when those cells lose control, and they usually grow too fast and they don't mature properly and they're not dying properly. So in the case of colon and rectal cancer, it's a colon cell that has lost growth controls and grows too fast and then starts to invade its neighbors and spread to other parts of the body, and that's when it becomes a malignant cancer.
So what do we know about colorectal cancer rates in Vermont?
So Vermont is, well, first of all, nationally, colorectal cancer rates have been declining for more than a decade now, probably because of improved screening and taking out precancerous polyps.
And that's for people over 50, right?
And that's for screening for people over 50. Vermont tends to be a little bit better than average in colorectal cancer rates. The rates, as you can see on the slide here, are not even throughout the state of Vermont. There are some counties that have a little bit higher rates than others. The screening rates are uneven, and there are some counties where screening rates are a little bit lower, and that is probably one of the reasons that there's more colorectal cancer in those counties.
Okay. And you were mentioning that population plus not enough screening plus not access to screening are some of the reasons why that map showed those incidents.
Right. We're not sure exactly why all the variation. Some of it may be screening. There are not a lot of major risk factors for colon cancer, the way smoking is a major risk factor for a lot of cancers.
Right.
But in general, what I tell people is that what's good for your heart is also good for your colon. So you've heard a lot about increasing obesity rates in recent years, and it's thought that that increasing obesity rates is a bit of a risk factor for colon cancer, and this may portend not well for the future if that continues. There may be the variation in that national map that you saw in colorectal cancer rates is pretty well parallel to the variation in obesity rates across the country. Places that have more obesity have more colorectal cancer patients. Places like Vermont that have less obesity have less colorectal cancer.
Can you talk a little bit about some of the risk factors? Age, I mean, we always hear if you're over 50, you should be screened.
Yes, so colorectal cancer, like many other cancers, is a disease of aging. The more time your cells have been around, the more time they've had to develop abnormalities. Age is one thing. Family history is probably the next most important thing. If a first-degree relative has had a colon cancer, that significantly increases your risk for cancer. And then what I said before about what's good for your heart is good for your colon. So diets that are high in fat, diets that are high in red and processed meats are bad and are associated with increased risk of colon cancer. Diets high in fruits and vegetables are better.
And so you talked a little bit about the fact that there's a dramatic increase in colorectal cancer rates in younger adults. Talk a little bit about that, because we've got a whole generation now coming up, and you think that maybe these numbers are just the tip of the iceberg.
It's possible. So there was a study that was released a couple of weeks ago and got a lot of play in the media about significant rises in colorectal cancer rates in younger people, under 35, under 40, and that's true. The rates in people over 50 have been going down steadily, especially over the last 10 to 15 years as colorectal screening with colonoscopy has become more popular. So we're very happy about that, but hidden in those statistics is that rates are rising for younger people. The final rate is still much higher in people over 50 than it is in people under 40, but the trend is worrisome in younger people, and it matches the trend in obesity that we've seen in the last 25 years. So that nobody knows for sure, but that's one of the plausible reasons why colorectal cancer rates may be going up.
Now, an area of expertise and research focus for you is on the genetics of colon cancer. How important is the genetic risk in colon cancer? I mean, we always hear about the BRCA gene for breast cancer.
Right. So the proportion of colon cancers that are thought to be due to a single genetic factor that you've inherited is about the same as breast cancer. It's thought to be about 5%. Mm-hmm. The most common condition that predisposes to colon cancer is called Lynch syndrome. That's about 2.5 to 3% of colon cancers are thought to be due to Lynch syndrome. That happens when you inherit one of 4 different genes that make proteins that help us fix DNA mistakes. The risk for colon cancer in those families is so high that we try to identify them. And now, in most of the country, and Vermont was one of the first places to do this, we are testing every colon cancer that is even biopsied for the presence of Lynch syndrome. So if you've had a colon cancer that's been positive on biopsy at University of Vermont Medical Center, or a colon cancer anywhere in Vermont that's been removed, we'll do this special testing in the pathology lab to see whether it looks like this is a Lynch syndrome cancer or not.
And then what happens with that information, and why is that important?
Right, so if we can identify those people, we will then refer them to our familial cancer program and try and do genetic testing. If you identify those people, they have a very high risk of colon cancer. The general population risk is about 5 to 6%, mm-hmm. and maybe going down a little bit because of screening. For Lynch syndrome people, the risk is 30 to 60% lifetime of getting cancer. So very high risks. We start screening earlier and we screen more often because in those families, the progression from a benign polyp to an actual cancer happens much faster. So you can't skip 10 years if you have a negative screening if you have a hereditary cause of a colon cancer. So we can prevent these, and it's been shown for the general population that colonoscopy prevents colon cancer, and it's been shown for Lynch syndrome that more intensive colonoscopy saves lives also.
Tell me a little bit about how a colonoscopy works.
Well, a colonoscopy is a colonoscope is a flexible tube, a scope that is inserted through the rectum and goes all the way up to the end of the colon. In an ideal colonoscopy, the endoscopist can see and even get the scope into the end of the small bowel, so he knows he's been through the whole colon, and then slowly removes the scope, and it has a camera on the end of it, and we're taking pictures the whole way. So the endoscopist is looking for any masses, and he hopes not to find a cancer. The most common thing that endoscopists find is polyps.
Mm-hmm. And what are they?
So polyps are little outgrowths of colon tissue. At the very early stages, if colon cells are growing too fast, then they sort of outgrow their space and they form a little bump. Almost all of those are benign, and only a minority of them might turn into cancer. But over the years, those are cells that are prone to overgrowth and not dying properly, and then they can gather more abnormalities. So if an endoscopist sees that, they have a little biopsy forceps at the end of their instrument, and they try their best to actually remove the whole polyp during that colonoscopy. Which
you mentioned is really sort of the genius behind the procedure, because then you don't have to come back if something is found. It's like, well, we got it.
Right. Most of the time, they can get everything through the colonoscope. There are times where if there's, the pathologists review every specimen And if it looks like there are abnormal cells right where they took the biopsy, they'll go back again and either do a repeat colonoscopy to try and remove what's remaining, or occasionally people may need a surgical procedure to remove a little part of the colon.
Are there any symptoms for colon cancer?
Well, there are in the later stages, but in the early stages, there are often no symptoms. The lower down in the colon that the cancer is, the more likely there is to be bleeding that you can see. The cancers almost always shed some blood and shed some cells, but if that happens pretty high up in the colon, that blood is a small amount and it mixes in with stool, and you won't notice it. Rectal cancers may have symptoms because the rectum is so close to the end, and you may actually see the blood. So it's not common to see blood in colon cancer, although it's common to see it in rectal cancer. However, if you're losing blood over a long period of time, probably the most common symptom is fatigue, because people can become anemic from the blood loss over a long period of time. There are a variety of non-specific bowel symptoms that people get. There's no abdominal symptom that's specific for colon cancer. But the real message here is that often people can have a cancer and have no symptoms.
Right.
And that's the reason that we recommend screening. Screening means looking for disease in the absence of symptoms. So we recommend that people at age 50 in the general population get screened, because it's likely that there's no symptoms if they have an early cancer.
Are there screening options?
There are. The most common one and the most highly recommended one is colonoscopy. That requires you to undergo a prep, and everybody who's had a colonoscopy knows about the prep, and it's the worst part of the colonoscopy. You have to clean the colon out so that the endoscopist gets a good look at the tissue. And it has the advantage, as you mentioned, of being able to remove an abnormality that's seen at the same time that they see it. The other option, the other common option that is sometimes done now is called a virtual colonoscopy, or a CT scan that is so high resolution that it can see the little lumps and bumps in your colon. And it's been shown that good CT colonography or virtual colonoscopies can find the same number of polyps that colonoscopies find. The disadvantage of it is that the endoscopist is not there to be able to take out that polyp at the same time.
Right.
So you
still have to have the procedure.
You still have to have the procedure. And so in high volume centers in major cities, they will schedule a lot of those in one day, and they'll have an endoscopist standing by ready to do it so that the patient doesn't have to prep twice. If you were to do it in a place where there weren't a high volume, you'd have to prep twice to have the colonoscopy the second time. And then the last thing to mention is that I mentioned that there are DNA changes in cancer cells that are not in normal cells. So people for years have been trying to develop a test where you can see DNA changes in the stool, and then only do a colonoscopy if there are abnormal DNA changes in the stool. There are DNA tests on the market to do that, but they're not commonly done. But for people who can't have a colonoscopy or who are adamant about not having a colonoscopy, they can have stool tested for DNA changes, and that's thought to be better than testing stool for blood, which is what we did for many years. Okay,
we've got about a minute left. If someone is scheduled for a colonoscopy, what should they bring with them the day of the procedure? How long does the procedure take?
The procedure itself is, it depends on whether or not there needs to be a polyp removed, but the procedure itself is, I don't do them, but I'm guessing about 20 minutes, and I was asleep for mine, so I can't tell you exactly. The main thing you need to do is to do the prep properly, so that all the stool has been clearly washed out and the endoscopist has a good view and can see everything. It's to your advantage to do that. Yes, you want to make sure that they have a good view. If they don't, they may recommend that you have a second colonoscopy a little bit sooner. And no one wants to hear that. No one wants to hear extra colonoscopy. Dr. Greenblatt, thanks so much for joining us. And for more information from the UVM Cancer Center, you can check their website, vermontcancer.org. That's vermontcancer.org. Or you can call the number on your screen. It is 802-656-4414. That's our program for today. Thanks for joining us. I'm Judy Simpson. I'll see you again next time on Across the Fence.